So once again, thank you everyone for spending your short break with us this afternoon. My name is Shai Adelson. I'm one of the founders of Fort Health. We provide behavioral health care in terms of therapy and psychiatry for ages 4 to 24. And for the last couple of years, pretty much since the beginning, our one of our dearest and biggest partners has been Advocare Doctors. And this is, well, I'll let you introduce yourself.
Hi, everyone. I'm Dr. Sara Harmon. I'm a child and adolescent psychiatrist. I've been working at Advocare since 2019. I'm the behavioral health medical director, and clinically at Advocare, I do a lot of collaborative care, integrated care, which involves a lot of working with pediatricians who are providing medication management for pediatric patients. So I'm very happy to be here and glad to be collaborating with Shai on this project.
Excellent. Let's go next slide, please. Yeah, so this thing before we get started, obviously it's intended for educational, informational purposes. It will not be constituting medical advice or recommendations. The information is based on current knowledge and research. Obviously, it should not replace your own clinical judgment. I want to start with why we decided to run this program. Pediatricians provide more behavioral health care than any behavioral health provider, according to data from the American Psychiatric Association. 93% of kiddos will see their pediatrician each year. 3 out of 4 kiddos will be diagnosed at your office. 85% of psychotropic medications will be prescribed by people like yourselves, and up to 64% of pediatricians report discomfort with prescribing. So while we at Fort Health, we both take referrals for fee-for-service care from over 600 pediatricians. We do the best job that we can. And with the good folks at Advocare and with Dr. Harmon's leadership, we developed a collaborative care model that does integrated care with pediatricians, and the model is effective and it's wonderful. I have nothing bad to say about it. However, it is not enough. There simply aren't enough providers that we can recruit. It is a zero-sum game. What we have to do is increase pediatricians' capacity to treat mental disorders in primary care settings. We absolutely have to do that. And as specialist providers, this is part of our commitment to put in place programs and training programs and initiatives and all sorts of ways that we can do that. So in that way, ourselves and the good folks of Advocare, we have 100% aligned interests. We need to increase your capacity and comfort to treat those things. So this program is hopefully merely the first initiative that we will do, and ideally with feedback from you, understanding more of the pain points, more of the things that stand in your way to treating more of these cases, and hopefully we can go on this journey together and work on those things. Today is the first chapter, if you will. There are 2 additional ones in this summer program of training. We want to make this as interactive as possible. So if there are any questions about anything that you see today, please don't wait until a Q&A in the end. Use the Q&A feature, ask those questions, and we will try to make this into a conversation. With that, Dr. Harmon, let's get started.
Okay. Let me just, okay. All right, Shai, can you let me know if there are questions and maybe interrupt me as I'm kind of going through here? And then
Absolutely.
I just wanted to say quickly also that if there are questions, you can feel free to put them in the chat as well, and I'm happy to try to address them. Or if it's something I really can't address, I am happy to find an answer for you, and we will have a follow-up session that will be more of an informal opportunity to talk about the same material. And so I will try to get that information to you. Okay, so we're going to focus, sorry about that. Today's talk, on a little bit of didactic information, some cases, and then an opportunity to ask questions. And the focus today is really stimulant prescribing and stimulants as treatment for ADHD. So I did want to make a couple of comments to start on ADHD diagnosis in the pediatric medical home and just in general, a couple things that I see that can sometimes be areas where there might be opportunities to do better. One is in terms of making an ADHD diagnosis, I just wanted to remind everyone that the DSM criteria for ADHD requires that you establish that there is impairment in more than one setting. So typically that's school and home, and sometimes it's school and community, or school and social interactions, academics and social interactions. And some people will assume that means that there always has to be completely positive Vanderbilt forms or some other type of screening form from both the school setting and the home setting. And so I just wanted to encourage you to consider that sometimes a parent can be a really good source of collateral that can establish areas of vulnerability or areas of impairment both at home and at school. Teachers are really good at observing kids, but they're not perfect. Classrooms are big. Sometimes they don't exactly know what's going on with the kid. And so I will occasionally establish a diagnosis of ADHD, even when the teacher Vanderbilts or the teacher screening forms are not astoundingly positive. And I do that based on either what people in the community tell me or what the parent tells me about the child's struggle in different settings, if I think they're reliable. Another thing I wanted to just highlight is that the AAP clinical guideline for treating ADHD does recommend initiating an evaluation in relevant patients ages 4 and up. And so the preschool population, there's hesitance to make a diagnosis of ADHD. There isn't as much research, but I did want to kind of highlight this. I don't know that necessarily it is always appropriate for this diagnosis to be made in this age group in pediatrics. However, there are times where it's kind of like really dramatic. So the child that doesn't have trauma, that doesn't have other stuff going on, that has a strong family history, that has been asked to leave multiple preschools, that probably would have like really consistently positive Vanderbilt forms. That is a kid that you could potentially consider trying to make an evaluation for. And obviously, if there's access to developmental pediatrics or child psychiatry or other opportunities to make the diagnosis, you could consider referral as well. I do staged evaluations sometimes. So I will see someone and I will say, look, I don't have enough information to make a diagnosis of ADHD, but I'd like to see you in follow-up. Maybe we'll implement some behavioral strategies. And I'll tell them, like, over time, as I get to know you and you tell me more of the things that you struggle with, there may be enough information to make a diagnosis of ADHD. I am doing this often in my older teens and young adults who come in, they've never been identified before, and there's really a question of whether or not ADHD is there. I just kind of give it some time. Sometimes also with school-aged kids, we get multiple years worth of Vanderbilt forms. So maybe one year they have a really accommodating teacher and the teacher doesn't feel like there's really a significant impairment. And then the following year, the teacher has a really different observation or a set of teachers. And then just a comment I think a lot of you guys already know about inattentive type ADHD, which is that inattention can be harder to appreciate, and it's harder for teachers to appreciate too than combined or hyperactive impulsive type ADHD. Okay, so moving on to the treatment aspect of this, which is really going to be where the main focus is. I did want to reiterate, and I think a lot of you guys probably already know this, but stimulants really are the first line treatment for ADHD. If somebody has a diagnosis of ADHD, particularly if they're ages 6 and up, both the American Academy of Child and Adolescent Psychiatry and the American Academy of Pediatrics agree that they should really be offered a stimulant medication. And I know that sometimes there are barriers like parent agreement to this and community perception and access and all these different kinds of things. But medically speaking, the recommendation is that kids with ADHD diagnosis should be offered stimulant medication because stimulants are more effective than the other treatments we have for ADHD, and they're felt to be safe. So I did want to go through and just talk a little bit about the data. So there is a large prospective randomized controlled trial called the MTA trial, multimodal treatment of ADHD. It's pretty old now, but they followed patients for some of them up to age 25 in this study. So now we have some more longitudinal data, all from the same study. And what they found is that when they combined medication or a combination of medication and behavioral therapy, that beat just providing behavioral therapy on all the reports pertaining to ADHD symptoms. So basically, parent and teacher ratings indicated that kids who were taking medication or who were getting medication and behavioral treatment did better than kids who received the study intervention behavioral treatment. And then similarly, they looked at, okay, what happens when we compare this to just whatever's happening in the community? The community treatment was just, it could be medication, it could be therapy, it was whatever is happening in the community. And so again, they found that their medication and combined treatment arms beat the community treatment. But the behavioral treatment arm, just therapy, did not beat the community, whatever was happening in the community. So you can see, like in the title of this slide, roughly speaking, medication was equivalent to medication and behavioral therapy, and it was better than just behavioral therapy or community treatment as usual in the MTA study. Okay, so now we're going to talk briefly about the mechanism of action. I do use this to talk to families about what's happening with ADHD or what we think is going on. We don't completely understand the pathophysiology of ADHD, but we think that norepinephrine and dopamine are implicated, and that there's certain brain structures that have functional MRI findings that indicate that there are differences. So the prefrontal cortex, the caudate basal ganglia, anterior cingulate cortex, and cerebellum are all implicated in ADHD. The clinical impact of differences in these areas is that there's impaired regulation of attention, thinking, learning, and inhibitory control. So one thing to just kind of point out that I like to explain is it doesn't necessarily mean that somebody has an absence of attention or they are unable to attend for a long period of time to something, but it can be more about regulation of attention, like putting their attention on something when there are distractions, putting their attention on the teacher when they're thinking about something else. So that regulation of attention, the attentional control, is sometimes impaired. And then the associated clinical symptoms that we see, as you know, distractibility, forgetfulness, impulsivity, poor planning, and hyperactivity. And so why do stimulants work? Okay, so stimulants basically increase dopamine and norepinephrine. So amphetamines do that by direct induction of catecholamines, and methylphenidates do that by blocking a transporter that leads to, so it's like a reuptake inhibitor similar to an SSRI. Either way, you end up with more free-floating dopamine and norepinephrine. Okay, so I wanted to highlight a couple of things that I think are just kind of relevant that come up relatively commonly for me in my daily practice, but are not necessarily, may not be the areas that you guys are most familiar with in terms of treating ADHD. So one is the use of stimulants in the preschool population. So I did want to talk about the considerations for treating preschoolers with stimulants. I see a lot of alpha agonists being used in the community among psychiatrists and pediatricians for this age group. The guidelines do recommend that preschoolers have behavioral therapy first. And you'll note that I emphasized in here parent and or teacher administered behavioral therapy is what we're going for. So if the child is going to therapy and they're meeting with a therapist once a week and nobody is meeting with the parent to ensure that the parent is delivering something, an intervention to the child, that's not what we're talking about. So it should really be something called parent behavioral management training or parent behavioral therapy. The idea is that you teach parents how to parent in a way that is targeted to the ADHD brain. And similarly, the school intervention should reflect that as well. Stimulants can be a first-line pharmacologic treatment in this age group. So I do use stimulants sometimes in this age group. I did want to emphasize there is an FDA approval for one stimulant in less than 6. However, it's not actually the one that I would recommend starting with. So the clinical practice guidelines and other studies support choosing methylphenidate, even though it's dextroamphetamine that is approved, if you're using a stimulant in preschoolers. And so methylphenidate has the best safety and efficacy data. There has been actually a randomized control trial in preschoolers as well called the PAT study. Everyone in that study completed an initial parent training phase, and then they used a dose escalation. So they found that kids were getting about 15 milligrams a day of immediate release Ritalin. It was divided 3 times a day, so that would be like 5 milligrams 3 times a day. It was a positive trial, so the stimulants helped. However, there was less benefit based on effect sizes as compared to the school age trial, and there were more side effects in the preschool trial than in the school age trial. However, I just want to say that in comparison, we really don't have a lot of randomized controlled trial data for alpha agonists. So they don't have FDA approvals for ADHD in this age group. There was a 2021 retrospective study that was a chart review that tried to kind of parse out our alpha agonists better than stimulants. And it was positive towards alpha agonists, and I do use alpha agonists a lot, but just as a reminder that stimulants are a valid a treatment option as well. Okay, so I know that this diagram is always really hard to look at in terms of the different categories of stimulants, so I'm not going to spend too long on this, but there are a few things that I wanted to highlight. So as you know, there's 2 big categories of stimulants, and basically everything else falls under those categories. There's methylphenidates and amphetamines. In both categories, you have a dextro or just the left-handed enantiomer. So dex methylphenidate, which is your focalins, and methylphenidates, which is the mixture, the racemic mixture. And then similarly, dextroamphetamine is just the D enantiomer. And then amphetamine is a mix of the dextro and levo racemic compounds. And then within those categories, you have short-acting and long-acting options, and both focalin, so dexmethylphenidate, as well as dextroamphetamine have a prodrug. So the one that's really commonly familiar is Vyvanse. That means that what the patient swallows is not dextroamphetamine, but it's cleaved in the stomach and becomes dextroamphetamine. And Astaris is the same thing, but for focalin. And one other thing I just wanted to point out on this table, this long list here that has Cotempla, Abtensio, Concerta, Clovent, all these long-acting methylphenidates, they differ in their delivery methods. So there's liquids, patch, chewable, etc., oral dissolving tab, but also in how the release of the methylphenidate. So for example, Ritalin long-acting, 50% releases early, 50% releases later, and Metadate CD, it's 30% and then 70%. So that's another difference between these stimulants. I will say, I don't go crazy trying to figure this out always, because there's insurance and availability limitations, as everyone knows right now. So sometimes the really like refined decision for a patient isn't realistic because of other considerations. But sometimes I do consider these things if I'm switching. Okay, another thing that I wanted to talk about today is the considerations for treating ADHD plus irritability with stimulants. So clinically impairing irritability affects 25 to 45% of children with ADHD. So we know that irritability occurs in a large portion of patients with ADHD, and it's not clear whether this is like a subtype of ADHD or just should be part of the diagnostic criteria for ADHD. There's different theories about how irritability should be considered. However, what I wanted to talk about is sort of how do you approach ADHD treatment when there is irritability, since that's super common. So people have looked at that. Somebody did a meta-analysis in 2017 where they looked at 32 trials, and what they found was that actually methylphenidate derivatives were associated with decreased risk of irritability compared to placebo. However, amphetamine derivatives were associated with an increased risk of irritability. So if I'm thinking about irritability, I tend to favor methylphenidate stimulants. People have also looked at the MTA data. So again, the school age ADHD study, they specifically looked at improvement in irritability, and they found that irritability improved in the medication and combined treatment arms, but it didn't improve in the behavioral treatment arm, and it didn't improve in the community, or rather the medication and combined treatments beat out the behavioral and community treatments. So what that tells me, and people who study ADHD, is it suggests that treating with a stimulant can improve irritability in kids with ADHD. Some of them, let's say the reality is that some of them don't improve and some of them do become more irritable. Okay, I'm going to take a pause here. I'm going to transition into some cases and some more information, but I just wanted to touch base on questions, if there's anything that has come up.
Not yet. Everyone, please use the Q&A feature or raise your hand, and we'll be able to give permission to speak there. Yeah, let's get into cases.
Okay, so our first case is around starting a stimulant for ADHD. So this is a 6-year-old male. He's otherwise healthy, JR. He's been newly diagnosed with ADHD combined type. Parents have already tried behavioral interventions, and he has a 504 plan at school, and the family is interested in trying a medication. And so I wanted to comment on, I know this is a busy slide, I'm sorry, hopefully this can also be a reference. I wanted to comment on some of the things I consider when I'm starting stimulant medication for someone. So one is the individual history for the patient. So this table comes from it didn't originate, but I got this information from the American Academy of Pediatrics ADHD toolkit in terms of doing the individual history screening. And so I think it originally came from the AHA, where these questions came from. So you're going to want to ask about individual history. Is there a history of fainting, seizures? Has the child seen cardiology for any reason? Have they passed out during exercise in particularly? Do they have a history of high blood pressure or a heart murmur? And then family history, we're looking for sudden deaths in young people for cardiac reasons or unexplained reasons. And then also I specifically ask about arrhythmias, and I use the words hypertrophic cardiomyopathy, Brugada syndrome, WPW, just to see if I can kind of jog anyone's memory about arrhythmias. I do like the AAP ADHD toolkit for this. They have a nice handout that talks about, okay, if somebody says yes on one of these family history items or individual history items, like what are the true contraindications for stimulants? And the reality is that there are very few clear contraindications for stimulant medication from a cardiology standpoint, but I do sometimes ask patients to get a cardiology consult or EKG before I would start stimulant. And on physical exam, before starting a stimulant, you're going to want to do a cardiac exam for murmur, irregular rhythm, blood pressure abnormalities, and physical findings of Marfan syndrome. Okay, when I start a, and just a comment in terms of like the practicality of this. So some people will have this be a form that families fill out as part of the information gathering for making a diagnosis of ADHD. And I think that's a nice straightforward way to do it, right? So you can gather the family history at the same time that you're assessing the patient for ADHD. The next thing I do is I talk to families about risks and benefits, and I like to divide my risk benefit discussions into common, but typically mild, rare but serious side effects, and then other things to talk about the medication. So you can see here, I'm primarily talking about loss of appetite and the possibility of insomnia, abdominal pain, weight loss, headache, though I don't see that as commonly, and a comment on emotional lability or irritability when starting a stimulant. And then I usually will tell people there's a very rare risk of seizures and cardiac events. That's when people have an underlying, risk that we don't appreciate. That's why we do the screening ahead of time to make sure that there aren't any family factors. And I talk about psychosis. There is a 0.1% chance that somebody would develop psychotic symptoms with taking a stimulant. That's typically like a transient experience, and that I have seen once in a generally healthy population, but in general, it's stimulant misuse or like inappropriate dosing that would result in this side effect. And then I do talk about height. So there is a difference in long-term height attainment of about 2 centimeters in some studies that has been established for patients taking stimulants. And those are patients taking stimulants 7 days a week for a period of, I think it's years that they've looked at. So many patients in reality are taking stimulants a little more irregularly, for better or worse, than what this is associated with. And then high blood pressure or an elevation in blood pressure is the other consideration I talk to families about. You usually wrap up by saying they're generally well tolerated, and some really good things about stimulants are that you can start them and stop them pretty easily. So if the child has any issues, it's not like they're stuck for a long time waiting for the stimulant to leave their system. It's a matter of hours. Okay, and I do talk monitoring. So I talk to families about monitoring, and this table that I made comes again from the AAP ADHD toolkit, but this is also really kind of my practice. And the reality is that pretty much at every follow-up visit, once a child is stable on a stimulant medication, I'm checking blood pressure, weight, reviewing family history, review of systems. So are they having any chest pain, palpitations, problems with their heart? And I'm trying to get Vanderbilt forms, maybe not every follow-up visit, but like twice a year, ideally. If I'm titrating and I'm seeing a patient every 2 to 4 weeks, I may not get these measurements every single time. But I try to do it as often as I can, because I know that sometimes people miss appointments or they switch to telehealth or whatever it might be. So when they're available in my office and I can get this information, I try to. I will just finish this up and then I'm going to take a look in the chat, see. There's a couple questions. So, okay, so what stimulant do you start for a kid who's never been on a stimulant before? So the reality is that I use a lot of methylphenidate. I like methylphenidate because it's favored in the preschool population. It's the medicine that was studied in the MTA and PATS trials. It's favored when there's irritability, which there often is. And actually the UK guidelines, the NICE guidelines, recommend starting with methylphenidate for ages 5 and up, even though the United States guidelines don't differentiate between methylphenidate and amphetamine stimulants. So I use a lot of methylphenidate, and that's what I will usually start with unless I have a strong reason not to. And this is a resource that I just threw in here. If you guys have not seen this yet, it's really nice. It's called the ADHD Parents Medication Guide. It's published by the American Academy of Child and Adolescent Psychiatry. You can Google it. The link is in the slides. I just usually Google it and print it out for families. It's like a lengthy PDF that's very well done, that talks about all the different medication options, including stimulants for ADHD. So that is a great psychoeducation resource. I'll pull up. Okay. Okay.
So we have 3 questions in the chat.
Yeah, I saw, okay, so there was a question about when would I start a preschooler on methylphenidate? And I would say there are varying situations, but if I'm pretty confident in the diagnosis of ADHD and I don't think that there's trauma contributing, I will, and the family is on board with it, I will often explain to them, like, I think this is more effective than the alpha agonist in terms of the information that we have. And I will do a stimulant trial. Doses, and then it depends a little bit on the size of the kid and how old they are. If they're close to 6, like I just started a 5 3/4 age preschooler who was a larger size. I will typically use an immediate release formulation first. I like the chewable methylphenidate, and I'm using between 2.5 and 5 milligrams twice a day, is typically what I will start with. And I just tell families, if you try it once and you have a bad day, and it doesn't go well, stop it and reach out to me and we'll talk about next steps. And yes, the height. Okay. Yeah. The height. Right. So I was going back and reviewing the height data as well. And that is the height data that came out of the MTA study that I have put here. There are other studies that have not replicated this. And so I do tell people that it's possible, but I don't know that the evidence is extremely strong that we're really seeing that. Certainly, it's variable. And again, most people are not, even if we ask them to, they're not taking their stimulant 7 days a week super consistently. And many families are not giving it on the weekends, not giving it on in the summer, skipping doses. And so, that may impact that as well. But yeah, the data is a little mixed on that. But this is from the MTA study. Okay. And which methylphenidate product is my go-to? I love Concerta. That's my go-to to start with. If it can be the brand Concerta or the Oros generic, which is like a, prior, what's the word? Like prior, can't think of the word, but anyway, like basically a unique delivery method that makes it like kind of a smooth delivery without sudden changes throughout the day. That's what I like. My other favorite methylphenidates are probably a mix, honestly, depending on insurance. I have some people on Ritalin long acting, and I have some on Metadate CD. So I use those a fair amount as well. Oh, and Quilivant is really good. Some kids who don't, for whatever reason, don't respond to the methylphenidate pills seem to do very well in the Quilivant liquid. I don't have a good explanation for that, but it can be harder to have it be approved. Not everyone has coverage for that, but if it does, I've had some people have a lot of luck with that.
There's a follow-up on what happens with a child that has significant abdominal GI on that. What's your next preferred?
Yeah. You know what, actually, I'm going to go through the case and then I will talk about that because we're going to talk about side effects. So JR is now 7. He's been taking Concerta 18 milligrams daily for 6 months. In that time, he's had a 10-pound weight loss and his mother is concerned. He's more irritable since starting the medication. So he's having side effects. Okay, so this table is my side effects table. There's a lot of writing here, but the reality is that pretty much for the side effects that arise, you have a couple of like categories of things you could do, right? So you can reduce the dose, you can switch to a different formulation, you can add an adjunctive medication, well, and sometimes you can do both of those things, reduce the dose and add an adjunctive medication. But there are a few things I'm going to comment on. So, because you had asked it, the specific question was about GI distress. So if somebody has GI distress with the initial stimulant, and they're not seeing any improvement, then I probably will try a different stimulant. And honestly, for that, I mean, Quilivant is one that I have seen kids do better on for GI distress. Daytrana patch, if you can get it, because it bypasses the GI tract because of its delivery method. So that is another one that has rationale for having fewer GI side effects. The other thing that I have interestingly seen is that kids who complain of belly pain, even older kids, like I had someone who was 17 that this was true for, I will sometimes add cyproheptadine to manage not just appetite suppression, but also GI distress, right? So if they're doing really well on the stimulant, if it's helping them, but they just can't tolerate the GI side effects, you could try adding cyproheptadine or periactin for that. That also helps with the appetite suppression. Other things in terms of GI distress, so sometimes it's things like splitting the dose, switching formulation, having a meal before they take their, eating breakfast before they take the stimulant rather than giving it on an empty stomach. All of those types of things can help. But yeah, I would say if there's a lot of GI distress, on my first choice, I would try maybe Quilivant or the Daytrana patch, and as some of my next options, or add cyproheptadine. Let's see, other comments on here, just on the managing side effects. So yeah, I did want to comment also on the cyproheptadine. If you guys are not doing that regularly, that can sometimes be really amazing for kids who have weight loss or who are not eating well on their stimulant and then they're cranky and irritable. Use typically 4 milligrams or 48 milligrams at night, depending on the age of the child. If they're very young, I might do 2. And for the kids it works for, it's like amazing. It really works quickly and well, and they are often a lot happier because they're better fed. I also add alpha agonists a lot to manage stimulant side effects. If the ADHD is still not sufficiently managed, but we're having side effects, then I might, like their blood pressure is elevated or they're more irritable, I might add an alpha agonist like a guanfacine or clonidine. I use more guanfacine than clonidine typically. Insomnia, I like to just switch to a shorter acting formulation typically, and just some psychoeducation around making sure that they're not taking it too late in the day. Because there are times when when people are complaining of insomnia, it turns out they're taking the medication quite late. This is more like in the teenage adolescent population. They take it at noon when they wake up on the weekends, and then it messes up their nighttime sleep. Okay. Okay, so this is part 2. So there have been some efforts to add healthy calories into his diet. His weight hasn't stabilized. He continues to be irritable. So his mother doesn't want to try cyproheptadine and insists that there must be something better he can try. So in this example, okay, so I want to talk about switching stimulants. So guidance for switching between stimulants. So I have seen different pieces of guidance out there about how to do this. What I typically do clinically is I determine an equivalent dose between the two things that I want to switch in between. And then I consider using slightly less than the dose equivalent to start with the new medication. So let's say I want to switch from Adderall XR, 10 milligrams, and I want to switch to Ritalin long acting, which the dose equivalent would be 20 milligrams. And so maybe I start with 15 of the Ritalin because I want to kind of go a little bit less than what I think the dose equivalent would be, just in case the patient responds differently to it. If it's young children, if it's people who are complaining of a lot of side effects, if it's families who just have a lot of caution and sort of hesitance about using the medication, I will just restart the next stimulant at the lowest starting dose. So that ends up happening a fair amount as well. But for my patients who have been on high doses of stimulants for a long time and tolerating them well, I don't always restart them at the lowest dose because then it can take them a while. They can almost feel like the new medicine is ineffective because we're underdosing it. I wanted to make sure that everyone is aware of the ADHD medication guide. That's this thing. It's free online. You can Google ADHD medication guide, and it has pictures, the dose forms available, all the different new stimulant types. The one side is methylphenidate, the other side is amphetamines. It's a great reference. I use it a lot. Just kind of tells you what's out there and can be a reminder of, is there a liquid of this? Is there a chewable of this, etc. And then the other thing is there are dose equivalence calculators. So I linked 2 in here. So basically, if you're trying to switch between 2 stimulants, and I know with stimulant shortages recently, everyone has been switching medications a lot more often. There are tools. So one I use is this. This is the one I linked here, the ADHDmedcalc.com calculator. And you put in what you're calculating from and what you're calculating to, and it will give you an equivalent dose. I do try to do my own calculation based on, what I know. So I'm double checking with the calculator and not completely relying on it. But I like this as a double check. Like, here's what I've calculated. Okay, here's what the calculator calculated. And if you want to learn more or teach yourself more about doing the calculations yourself, I like this Psychiatric Times How to Switch Stimulants, a dosing guide for ADHD that goes through how to determine the duration of the stimulant and the total milligrams. And you have to consider both of those when you're switching between stimulants, because if the 2 stimulants you're switching between last for a different duration, then it's not just a simple, what's the relationship between the 2 sets of milligrams. Oh yeah, and but roughly speaking, so just to remember, I think probably a thing that I didn't know until I was doing this more was the relationship between methylphenidate and dexmethylphenidate. So dexmethylphenidate, which is Focalin, is stronger effectively. So at lower doses, at 10 milligrams of dexmethylphenidate is equivalent to 20 milligrams of methylphenidate. And that's because dexmethylphenidate is just the active racemic component. So all 10 milligrams of the Focalin is in theory active, whereas when you have methylphenidate, you have some inert molecule that's in there. Okay, so our case here, JR was ultimately stabilized on dexmethylphenidate, Focalin, XR 20 milligrams daily. He's now 16. He has a B average in school and he's not in therapy. He's begging his mom to stop his medication. So I wanted to talk a little bit about long-term considerations for stopping treatment for ADHD. So obviously this is not a really straightforward decision. And a lot of times teenagers, they have a lot of ability to control whether or not they take the medication anyway. So this is an individualized decision, but basically what seems to be coming out in the evidence is that medication and behavioral treatments don't seem to have enduring effects in ADHD. So like people with ADHD, it seems, for the most part, may need to have some level of support on a continuous basis, whether that's medication, behavioral treatments, or a combination. And when you stop those supports, their symptoms can recur. So if you look at the MTA study, they found that 90% of children followed into their adulthood continued to experience some form of residual symptoms. And there are previous studies that have found lower rates that have thought of a significant population with ADHD, their symptoms resolve in adulthood. I think that's beginning to be felt to be less true. And though there are fluctuating periods, so what seems to happen for most people is they'll have periods of remission and then periods of recurrence over time. So you may catch a young adult who's doing really well and who's stable, and then you may see them again 5 years later and they are symptomatic again. And then there are some people who seem to have more of a pattern of stable partial remission where they get somewhat better and then they kind of stay in that somewhat better state. But regardless, it's a small population who are symptom-free with no treatment in adulthood. And untreated ADHD has some significant associations. And again, this is complicated and it's not necessarily causation, but there's associations with lower academic achievement, social and peer problems, substance and alcohol abuse, job instability, and criminality, as well as higher rates of motor vehicle accidents. So in my mind, in general, I try to encourage families and kids and teens to find a treatment set of treatments or supports that is working for them and to stick with it. And, you know, I mean, does that mean like the person who's doing really, really well can't do a trial off of medication or a trial of less support? Yeah, absolutely. We would do that. But I think the reality is that a lot of people do continue to need supports, and there are highly creative ways that individuals with ADHD access those supports in their adulthood through workplace accommodations, through relationships, through formal therapy, through medication, etc. But yeah, I have some hesitation with somebody who's doing well coming off of their treatment because of this long-term information. Okay, that is the end of what I prepared, but I'm happy to answer other questions. I will pop back into the chat and see if anything else.
There's one on side effects, and while you look for that, what we want to do is a follow-up sort of informal case consultation session next week at the same time, where you can essentially bring your own cases as long as they're de-identified, and yeah, essentially have Dr. Harmon do a case consultation for you. The idea really is to copy or to get inspired by what they do at the REACH training, which is case-based. People bring their cases and we learn from each other. Obviously, no pressure to share, but if anybody is so inclined and you have more questions or cases, then next week we're happy to do that. We'll send an email reminder on it, and you contact me, and I'll get an invite out.
Great. Yeah. And with respect to the cases, obviously, I know that the cases that I talked about are relatively straightforward and simple, just raise some kind of common points about stimulant prescribing. I know that the reality is that things are more complicated often. So, you know, I'm happy to try to take a stab together at some of the complexity that comes up. And I can try to talk about some more complicated things that I sometimes see with stimulants. There was a question about Jornay. I like Jornay. I don't use it a ton, but that's not because I don't think it's good, and it has a place for families who struggle a lot with the morning symptoms. Yeah, so I think Jornay is good if you have access to it.
We have a couple more questions in the chat if you have a minute. So 6-year-old with ADHD combined, some ODD tendencies and anxiety. Would methylphenidate still be preferred?
Yeah, here, I'm going to scroll up a little bit because actually somebody was talking about ciproheptadine, and not finding it to be helpful for appetite. That's interesting. I mean, obviously it's anecdotal, right? I only have my own individual, and I mean, I'm sure there's data as well. I just had somebody gain 10 pounds in like 4 weeks on ciproheptadine who really needed to gain weight. So I find it's not always helpful for everyone. But I actually, that's a tool that I use not infrequently and I have good results with. Maybe it's placebo or something, but I have kids who really seem to do better. However, I would also say another option that I sometimes use, and this is getting a little bit outside of stimulants, but I have used mirtazapine, which is Remeron. It's an antidepressant with serotonin agonist, and it not for young kids, but for older kids who are having appetite suppression and who also have anxiety. Mirtazapine makes you very hungry as well. So that is if you're looking for an alternative potentially for appetite. And the age is reasonable. Okay, yeah, what age do Vanderbilts no longer matter? That is a great question. I think they're validated up through 17. But the reality is that Vanderbilts are basically a questionnaire that is based on the ADHD symptom, the DSM criteria. And so the validation studies are such that they're only up through 16, but you can switch over to something called the ADHD, I think it's called like the ADHD questionnaire. It's literally the same questions that some people, the CADRA, like the Canadian guidelines, recommend using. There is an ASRS, I believe, which is like an ADHD self-rating scale that you can use in later teens and young adults, that is also an option for self-report. But so I would say, yes, I acknowledge that the Vanderbilts are no longer validated beyond, once patients are beyond 18, but they're asking the questions about the symptoms that are the core symptoms of ADHD. So I think with it, while acknowledging that there aren't validation studies, I think it's still giving you valuable information if you continue to do them. Okay. 6-year-old with ADHD combined, ODHD. Yeah, I mean, yes. If there's a so the question, this is a good question. ADHD combined has some ODD and also has anxiety. And you're kind of deciding what to start for medication. So yeah, I would often try a methylphenidate if I'm going to try a stimulant. If there's anxiety or if there's ADHD and a comorbidity such as anxiety or depression, I try to determine which is most impairing as one of the reasons that as one of the considerations that I make to determining what to start. So if the anxiety is overwhelmingly impairing, I might do a medication for anxiety as well. But if we're doing a stimulant, then yes, I would do methylphenidate in that case typically. Okay. And let's see, what else do we have? Meds on a PRN basis. That's a good, okay. Yeah. Okay. So this question is about college kids and taking medications on an as needed basis. So some college kids who wish to take the medication on an as needed basis and comfort with that. And so this is a difficult question, but ultimately I do have some patients for whom the stimulants are helpful, but the side effects are really unpleasant and they try to kind of minimize their use as much as possible. And they're only using them when they really have to. And in that case, it's, patients I know well who I think are reliable, who don't have substance use concerns. I will sometimes, be okay with a consideration like this, with the understanding that they know that ADHD medication or stimulant medication does more than just help them with school, right? So it might be helping them with impulsivity, risk-taking behavior, those kinds of things. If they're opting not to take it often, they're probably putting themselves more at risk for that. But ultimately the data suggests that treating ADHD is protective against substance use disorder. So the concern about drug seeking, having an on-off pattern of utilizing stimulants contributing to substance use disorders, I don't think that's borne out yet in the evidence. I can see why it would be a concern. And the answer about the last question I see on here is are there RVUs associated with Vanderbilt screen? And I don't know the answer to that, but that is something I can find out.
Okay.
Okay.
So I think we are at time. So again, thank you, Dr. Harmon, for sharing your knowledge, for answering questions. Thank you, everyone that showed up. As you can see on the screen here, are 2 additional chapters on non-stimulant management of ADHD, August 1st, and then prescribing SSRI on September 11th. We will be doing the case consultation meetings a week after each of those sessions. Please email me for an invite to those. And again, even if you don't have a case, you want to ask general questions, by all means, we're doing these for you and to advance knowledge. So thank you again. And any feedback, by all means, let us know. We're looking to help you do your job better, help you increase your capacity to provide care for kiddos, and that's ultimately what we're trying to do, all of us together. So thank you again, and enjoy the rest of your day.
Thanks
Bye-bye
very
now.
much.